Hello, future nurses. Hope you guys had a great Thanksgiving. Let's talk a bit about Neisseria, gonorrhea, so this organism is a gram-negative coccus. It is not motile. Does not form spores. And it often appears as paired cells, and these pairs are called diplococci. They are catalase and superoxide dismutase positive. They are oxidase positive. When you isolate them, you grow them on Thayer-Martin agar. And this is made with lysed sheep's blood, so it's chocolate agar. Now, if you do a maltose fermentation test, Neisseria gonorrhea is negative, but Neisseria meningitidis is positive. So this is an important test for distinguishing between Neisseria meningitidis and Neisseria gonorrhea, because in a gram stain, these two organisms will look exactly the same. Now, Neisseria gonorrhea is decorated with lots of these pili. And you can see these pili here in this electron microscope picture of a freeze-fractured Neisseria gonorrhea cell. This looks a little bit like a golf ball that had the surface knocked off it. And these are all these little strands here. Those are pili. Lots and lots of pili on this organism. Here's some of the isolated pili down here. So this is a heavily, heavily pillated organism. So these pili act as adhesins they allow the gonococcus to adhere to a variety of different cell types, and they also play a role in DNA uptake. So Neisseria gonorrhea and other members of the genus Neisseria have the ability to undergo genetic variation via transformation. They take up DNA from the environment. That then gets incorporated into the genome, and therefore you get a respectable amount of genetic variation. This genetic variation is part of the reason that there is no vaccine for this organism, because it is so variable genetically. Part of the reason for that variability is due to this ability of the organism to take up exogenous DNA and use it as its own. Now, there are some other surface proteins that play a role in pathogenesis and in adhesion. Pili are a big part of that. There's also the so-called OPA, or opacity associated protein. Old books, old papers will call this protein 3, P3. OPA is definitely the term that's used the most. This protein and your pilus protein is subject to extensive genetic variation. And this is due largely to a replication process that makes lots of mistakes when these are made. Therefore, these two proteins that are very immunogenic vary tremendously, and the immune system has a really rough time staying ahead of the organism. So OPA can adhere to several different proteins. One of the big proteins it adheres to is something called the CEACAM. This is an abbreviation for carcinoembryonic antigen cell adhesion molecule. So this is mercifully abbreviated CACAM. OPA adheres to this particular protein, and this is important because this is very heavily expressed particularly in the female reproductive tract. Finally, there are two other entities that are important for adhesion. First of all, there's an external protein that is one of these pores in the outer membrane that allows things to come into the cell. So your porins. There is a so-called pore B. Pore B allows cells to bind mainly to cells of the female reproductive tract. And also immune cells. And then the gonococcal lipopolysaccharide, which is chemically different, so it's called a lipo-oligosaccharide. So remember, this is in the outer membrane, and this is capable of binding to urethral epithelial cells, and also, interestingly, sperm cells. So the organism has lots of ways to stick to the reproductive tract. And that is one of the reasons why this organism is so good at colonizing both the male and female reproductive tract. Now, the organism elicits from epithelial cells in the reproductive tract, a very strong initial inflammatory response. And so, neutrophils, your polymorphonuclear cells, are one of the first cells on the scene. But it's very clear that the polymorphonuclear cells are not capable of clearing the infection. And these will engulf the gonococci but they do a poor job of clearing them. So it's not uncommon to see a polymorphonuclear cell with lots of little, if you do a gram stain, you'll see lots of gram-negative diplococci in the cytosol of these cells. So the gonococci can survive inside the polymorphonuclear cells. There's several mechanisms by which they're able to do this. Giving you the Reader's Digest version, these cells make very, very large amounts of catalase so that hydrogen peroxide is converted to molecular oxygen and water. Then they also have other peroxidases that will assist in detoxifying the sorts of molecules made by the PMN, and then also these cells influence the behavior of the PMN so that their oxidative burst is not nearly as robust. Now, one other virulence factor made by Neisseria gonorrhea is an immunoglobulin A protease. So immunoglobulin A is the most important secretory antibody that is secreted across mucosal surfaces. And if immunoglobulin A is secreted, it will be degraded by the protease made by Neisseria gonorrhea. Now these will multiply inside the neutrophil. If the neutrophil becomes too loaded with these, it'll burst. These will then release the Neisseria gonorrhea into the blood. And then you can have a condition called a gonococcemia. Now from here, the Neisseria gonorrhea can disseminate to lots and lots of different organs. So the lipo-oligosaccharide can generate a very widespread immune system, leading to sepsis. So in sepsis, you will remember the blood pressure crashes. You have this massive vasodilation. You can't perfuse your tissues very well. And you start going into end organ damage. The organism can also infect other organs as well. It can infect the heart, and it can affect the joints. In your book, there's a very good picture of somebody with gonococcal arthritis of the wrist. In the heart, it can cause endocarditis. And if a woman who has gonorrhea gives birth, of course, she can cause neonatal conjunctivitis. And that can lead to a conjunctivitis of the newborn 2 to 5 days after birth. And if not treated, that can lead to blindness in the baby. Joints that are usually affected, there's usually multiple joints. So the most commonly affected joints are the wrists, ankles, and the elbows. And usually systemically, you'll get things like fever, chills, and malaise. And then, as also is the case with chlamydial infections, if you have pelvic inflammatory disease, you can have an infection of the peritoneum and then the Glisson's capsule that surrounds the liver. And then infection in the Glisson's capsule can result in so-called Fitz-Hugh-Curtis syndrome. And in this case, you have these adhesions. You get scar tissue of the tissue that attaches the liver to the peritoneum. So-called violin string adhesions. Of scar tissue that attach, that's an H, the liver to the peritoneum. So that's the case with disseminated Neisseria gonorrhea diseases. Most commonly, you're going to have a urethritis and female cervicitis, and then if it persists, you'll have a pelvic inflammatory disease if it's not treated in males. It can lead to prostatitis, epididymitis, and again, this is treated with ceftriaxone. Now, usually because you don't know if you're just treating this or chlamydia, this is usually given, again, this is given IM, so 250 mg IM, and then with a gram of azithromycin. And that is given per os. All right, so that is gonorrhea. right, I would now like to talk about syphilis, which is caused by Treponema pallidum. Treponema pallidum is a spirochete. So this spirochete is a cork screw shaped organism. The spirochete has a property called thixotropy. Namely, it moves towards areas of greater viscosity. That's unusual. Most organisms move away from areas of greater viscosity. I spelled spirochete the British way. Americans would not put the A in there. I spelled it the British way, so sue me. All right, so this organism is a sexually transmitted infection, just like gonorrhea, just like chlamydia. And when you have sexual intercourse, you have tiny cuts or breaks of the skin, the mucous membranes of the external genitalia, or perhaps the mouth. So this would include either oral, anal, or vaginal intercourse. People can also get this organism if they are a user of illegal drugs, so contaminated needles. Can also pass this organism. Then there's congenital syphilis, and in this case, a pregnant mother with syphilis passes it to her baby. Across the placenta. Now, the pathology of this organism is still not completely understood. So there are 3 stages to this infection. And I have a nice picture of the Treponema organism here. It's a little cartoon. So the organism is a gram-negative organism. Stains very poorly, though. It has the flagella underneath the outer membrane. So these are called endoflagella. So they're inserted into the tip of the organism. They rotate just like you would expect in other organisms, except because they rotate while they're embedded in the cell, they'll cause the organism to corkscrew like this, and that's how they bore essentially through more viscous tissues. That's also probably how they invade other tissues. Now, the organism can appear in tissue if you use the right stains. So this is a Stenner silver stain here. Let me see if we can get a little close up on this. So all the little dark doodads here that you can see, all of those are Treponema pallidum. The organism is very transparent, very hard to see in a light microscope sort of slide. You have to use dark field microscopy if you're going to see them. Typically, they'll show up pretty well on dark field. However, regular light microscopy, if you don't stain them, they're really hard to see. So here we have illustrated essentially the progression of this disease in its 3 stages. Let's go over these. So the first stage is so-called primary syphilis. And primary syphilis is the localized stage. It starts usually 1 to 3 weeks after Treponema pallidum lands on the skin or mucous membranes. During this stage, the spirochetes will destroy the soft tissue of the skin whenever they enter the body, and that results in a so-called syphilitic chancre. A syphilitic chancre. Now, syphilitic chancres are painless. They're painless. So if you were to take the term chancre, but take the U out, you make chancre because you're cured of the pain. That's my really silly mnemonic way of trying to remember this. So chancres are painless. That's one of their features. Chancres in syphilis have a hard base, a raised border. It's covered by a fluid rich in spirochetes that can spread to other parts of the body as well as to other individuals. In people who acquire syphilis through sexual contact, the primary chancre usually develops around the external genitalia. But for people who acquire syphilis by physically touching a lesion or some other way, the chancre may appear on the hands or some other part of the body. Syphilitic chancres will heal on their own for a few months, but during that time, some spirochetes will go to nearby lymph nodes, and they will cause a lymphadenopathy, lymph node enlargement. They get into the lymph and then the bloodstream. If syphilis is acquired through a blood transfusion, which can occur, there won't be any primary chancres. You'll just go straight into secondary syphilis. So during secondary syphilis, you have the dissemination stage. That's this stage here. The spirochetes enter the bloodstream. That's called spirochetemia. Spirochetemia. This causes generalized lymphadenopathy. And the spirochetes are found in blood nodes, as lymph nodes throughout the body. And spirochetes are very good at attaching to endothelial cells in vessels. So they infect endothelial cells and small capillaries near the skin, and they cause a maculopapular rash. A maculopapular rash with small bumps that are either flat or raised. The rash starts on the trunk, spreads to the arms and legs, usually to the palms of the hands, the soles of the feet, the genitalia, and then the mucous membranes. Sometimes these rashes can become pustular, in which case they're lined with white fluid pus, or they can be scaly and hard, in which case they're papulosquamous. In addition, you have smooth, white, painless, wart-like lesions. They appear on the genitals, around the anal region, and the armpits, and these are called condyloma lata. Condyloma lata. Latum is singular. Condyloma lata. These various rashes can erupt all over the body, and they are chock full of spirochetes, which makes secondary syphilis the most infectious stage. The rash usually resolves within a few weeks to months, and then after secondary syphilis, it goes into a latent phase. The disease is dormant or asymptomatic. During this phase, spirochetes can be found in the capillaries of various body organs and tissues. The latent phase can be divided into an early and late phase. Early latent syphilis, within about a year of the infection. During that time, the spirochetes will re-enter the blood, so that during early latent syphilis, they can still be found circulating in large numbers and cause the symptoms of secondary syphilis again. During the late latent phase, normally a year after the first onset of secondary syphilis, or excuse me, a year after the resolution of the symptoms of secondary syphilis, the spirochetes will stay within the tiny capillaries of various body organs and tissues, and they can cause a very severe immune response and cause tremendous organ damage, and that triggers the next stage, which is tertiary syphilis. Tertiary syphilis. So they will recruit, this is like a type 4 hypersensitivity reaction. So there's an immune response led mainly by T cells. They recruit phagocytes like macrophages. They cause a release of pro-inflammatory cytokines like tumor necrosis factor, interleukin-1, interleukin-6. And you get local swelling or edema, redness, warmth, and systemic symptoms like a fever. The plasma cells are involved, and they produce antibodies against the three main syphilis antigens. These include a species-specific antigen, cardiolipin, and you get these granulomatous lesions, and these are called gummas. Gummas. Gummas have lots of different immune cells that are surrounded by an innermost, outermost layer of fibroblasts. Interestingly enough, there are virtually no spirochetes inside the gummas. Tissue at the center of the gumma is anoxygenic and becomes necrotic. So you can get damage to the heart and blood vessels, that's cardiovascular syphilis. You get damage to the brain and spinal cord, that's neurosyphilis. And also the liver, joints, and testes. In cardiovascular syphilis, you have endarteritis, inflammation of the tiny arterioles that supply blood to large arteries like the aorta. So you have damage in the vasa vasorum, and that can lead to inflammation of the aorta and cause aortic aneurysms. In neurosyphilis, you get infection of the capillaries that supply the back part of the spinal cord, and this results in a wasting of the back of the spinal cord. This produces a condition called tabes dorsalis. Tabes dorsalis. So you have general paresis, loss of sensation, weakness, or even total paralysis, mostly in the legs. If they get into the capillaries of the brain, the spirochetes will cause slurred speech, altered behavior, memory loss, difficulty coordinating muscle movements, and even paralysis. Syphilis can also affect the eye, which I don't believe is shown here, but that can cause the pupil to lose its light reflex. That's called the Argyll-Robertson pupil. Argyll-Robertson pupil. It can still accommodate for distance, but it loses its light reflex. Let's talk about congenital syphilis. Congenital syphilis. So in early disease, which is in the first 2 years, that can result in the baby being stillborn, or it can have features like a maculopapular rash on the palms or the soles of the feet, and snuffles in the nose is blocked by increased secretions. Those secretions will contain spirochetes. Babies may also have organ damage to the liver and spleen, causing hepatosplenomegaly. Well as to the eyes, that can cause optic neuritis. In late disease, after the child is born, classic features include a so-called saddle nose, in which you have bony destruction of the nose, saber shins, in which the tibia is bent, Hutchinson teeth, in which the teeth develop small little notches, and then also hearing loss. Diagnosis of syphilis involves identifying spirochetes in the fluid from chancres. You can use dark field microscopy. There are also serological tests. So there's the rapid plasma reagent test. Then there's also the so-called VDRL, which is the Venereal Disease Research Laboratory test. This test detects the anti-cardiolipin antibodies. These antibodies are called reagin. This also detects reagin. These tests are not completely specific to syphilis. There are also tests that are more specific to syphilis itself. There's the T. pallidum particle agglutination test. And then there's a fluorescence treponemal antibody absorbed test. And both of these will actually detect the organism itself. So these are more specific to Treponema pallidum, and these are commercially available. Diagnosing congenital syphilis is a bit different. So typically, You want to look at the serology. And if the baby's serology titer is 4 times greater than that of the mother's, that suggests the baby has congenital syphilis. You should also take a look at cerebrospinal fluid and do the VDRL test. And then do x-rays also of the long bones. Treatment. Still, the treatment of choice for syphilis is penicillin G. Fortunately, Treponema pallidum is still very susceptible to penicillin G. So you give 2.4 million units, and you give that IM. In some cases, you can use doxycycline. That would be 100 mgs. BID twice a day. You treat for 14 days. If you use penicillin G, this can blast apart the treponemes so effectively. You might have the immune system going into overdrive. That's called the Yorrish-Herxheimer reaction. If that happens, you'll get a sudden fever, sweating, and then muscle and joint pain. May last a few hours to a few days. Really varies from person to person. And that, ladies, is gonorrhea and syphilis.